This podcast is intended for educational purposes only and is not medical or legal advice. Always follow your local policies, procedures, and protocols when functioning in your respective profession. Additionally, the views expressed by the speakers and owners of this podcast are their own and do not represent the views of their respective employers. Listener discretion is advised.
Alert Medic 1 response.
Ken, Josh, and Mustafa here. Welcome back to the Alert Medic 1 podcast. Well, welcome back, everybody, to the Alert Medic 1 podcast. Tonight, we've got a return guest, a great guy by the name of Okayest or Mike. Or
some people think I'm great, others don't.
He's back on with us tonight to talk about a controversial topic that we inadvertently launched into the EMS Instagram stratosphere a couple weeks ago with a innocent reel, but sparked a lot of controversy. So tonight's big topic is gonna be glucose checks in cardiac arrest and following treatment, and we'll see what else we get into. So the original whole premise of this was that we were just saying things that don't really jive in cardiac arrest anymore. We've talked about this before with Sam a couple months ago in cardiac arrest meds and when we shouldn't be using them. And we started it there, and then we relaunched it, and come to find out, this is like a latent, under the surface controversy flowing around all over EMS right now, and people thinking we should do it, we shouldn't do it, why we should, why we shouldn't do it. And just be up front here at Alert Medic 1, we're on the side of we're not going to check unless we have an indication to check. We're not going to just do blatant glucose checks and just give out glucose to everybody. And we got some reasons why. And if Moose, you want to kind of go into some of the reasons why we shouldn't be doing it, and then anyone else want to jump in and talk about it?
Well, honestly, I kind of want to hear other people's thoughts first, right? So I'll be honest with you. I did the past couple of weeks and everything. I've been trying to do more so and take an agnostic approach to this and just think about how does normal glucose physiology work? How does it work in a shocky state? How does pancreas function, operate, in a normal flow state and then in a shocky state? And then I kind of got super distracted and never finished that research. So that's the fact. But then I kind of looked at so Foam Frat did a really cool article that I think some of the folks on Instagram mentioned, and then I found some more recent research. So I want to throw it to the group first, see what you guys think, and then maybe I can bring up some of the stuff I found on the recent research.
Cody? Mike, who wants to lead it off?
Mike, you're the guest. Go first, man.
All right. All right. There are two things in my career that I have repeatedly experienced with the same result. One is I have worked probably hundreds of codes that I've brought to the hospital that we knew were dead. And this was when we used to work codes all the time in the field. Probably hundreds of times I've brought in a code and they put an ultrasound probe on the chest, and never once have I seen them say, oh, look, there's a little bit of heart activity. Never. They're dead. The other thing I've never seen or experienced is, now I've had plenty of cardiac arrests that were hypoglycemic. Some we suspected were hypoglycemic. Others, it was an incidental finding. We checked the blood glucose and went, oh, crap, look, their sugar's 20. I have never resuscitated a patient in cardiac arrest after giving dextrose.
Fair enough.
Same. I've never seen it be the, I guess, the linchpin in the ROSC. It's
Correct.
Not that. It's the timely defibrillation. It's the high quality CPR. It's whatever intrinsically or metabolically is being jump started by our care. That's what's doing it. I know people have talked about it, but I've never seen it. I've never, granted, I don't think I've hung D10 in an arrest since my agency went to it. D50, I seem to remember, back in the day, it was like that one of those shotgun meds at the end of cardiac arrest. Like, well, we can't rule it out, and we can get into why D50 is definitely not the choice anymore.
Mhm.
But no, I've never seen it do anything meaningful. I've seen some other cardiac arrest meds that are like not glucose.
You bring up a really good point with the effective CPR. In preparing for this, I did a bunch of reading, and everything I read just hits home the point that the only things that you can debate supraglottic versus endotracheal intubation versus apneic oxygenation, glucose, Narcan. You can debate all of the stuff, but the only thing that is pretty clear is that effective CPR and timely defibrillation is what saves lives in cardiac arrest. I used to think that the cardiac arrest and hypoglycemia was a result of, I'm trying to think of the best way to put this without making me sound like a moron. I guess the brain needing a constant supply of oxygen and glucose, you lose the glucose. I just figured the brain shuts down, gets some type of injury, for lack of a better term, and then you eventually die. But that's not how hypoglycemia kills you or causes you to go into cardiac arrest. And I did not admittedly know this. And it speaks to your point about effective CPR and defibrillation. As I have a study here by Reno, Daphna, Eichen, Chen, Vander Wheely, Jethy, and Fisher. I don't know if I pronounced any of those correctly, but basically they took rats and they gave them insulin to induce cardiac arrest. And the majority of hypoglycemia cardiac arrests, at least according to the stuff you can find on PubMed, are suspected to be due to insulin misuse or taking insulin and not eating, something of that sort. So it's definitely taking insulin issue. So they gave these rats insulin to induce cardiac arrest, and they found that as the hypoglycemia becomes severe, your QT interval prolongs and you become tachycardic, and then you become bradycardic, you develop heart blocks, and then you go into a VFib or VTAC arrest and die. So it's an arrhythmia that kills you. Now, I know you could say any cardiac arrest is an arrhythmia. You get hit by a truck and you go into PEA, that's an arrhythmia. But it's affecting the heart, which is what's killing you.
I'm so happy that you brought that up because this is literally it's in Diabetes, right? 2013 was the publication.
Yep.
Yeah, that was one of the articles that I had saved because in doing the research, and a lot of folks say that it's a rat model, so on and so forth. So let's be real here. We can't do a lot of this research in actual people because there's something called ethics. Right. So we have to use tools like this article. And I really like how they really dive into, like, just like you said, Mike, why these patients are arresting. Additionally, when we're talking about brain death, certainly hypoxia is going to be the thing that kills people before the hypoglycemia, I would imagine, and I would love to get your guys' thoughts on that. Exactly.
100%. I mean,
Yeah.
The sugar doesn't. You can have 1,000 grams of sugar in your system. If it's not circulating, it's not working. It's just sitting there. It's a traffic jam.
And the damage is done. If you go into a cardiac arrest and you become hypoxic, you could give them all the dextrose in the world. It's not going to make a damn bit of difference. It's just like if Josh, your patient takes his insulin and then coincidentally, before he gets to eat, has a massive stroke. So you have this infarcted brain tissue. Okay, you could correct the hypoglycemia. It's not going to do a damn bit of good for the patient if their brain's infarcted.
Right.
You're not going to reverse it.
6 to 8 minutes. You have 6 to 8 minutes
exactly.
of hypoxia before there's irreversible. I want to reemphasize that word. Irreversible brain damage.
Bingo.
And in cardiac arrest, you've got there at 8 minutes, 59 seconds, normal response metrics. And guess what? The damage, to your point, Mike, the damage is done. Go ahead, Josh.
So also on this, this whole, if we want to talk about, well, if the cardiac arrest was caused by hypoglycemia because they took insulin, they misdosed it, they purposely misdosed it. Yes, that happens. And So now they've been in a hypoglycemic state. So how long were they unconscious in the hypoglycemic state prior to finally going into arrest? Probably for an extended period of time. So they're going to have a decreased respiratory rate. And as that sugar gets lower, they're likely going to breathe slower, shallower, and they're going to be hypoxic before they even enter the state of cardiac arrest. So they're
Not too
going
much different
in,
from an overdose, right?
yeah, you're not going in like a cardiac etiology where, you know, Mr. John or whoever is walking through the park and just has a massive coronary and drops. Well, he was breathing just fine beforehand. He's at 100% when he drops to the ground. That's the person you've got 6 to 8 minutes. But the person that
Right.
was hypoxic going into the arrest, you have even less time. And, you know, that kind of speaks to our overdose arrest, that it's a hypoxia issue. It was a hypoxia issue for minutes, you know, probably, you know, over 10 minutes, maybe over 15 minutes, even before they finally got to the point where the heart was like, that's it, I'm done. And you're going in with, who knows, like a, you know, O2 saturation less than 50, you know, and it's just, yeah.
It's a good distinction to make, though, Josh. You know, did you guys see what just happened?
No, I missed it.
My train of thought.
Oh, okay. Yeah. All right. I thought your audio
Out
went
of
out
my face.
or something. I think that this brings up kind of an awkward, I don't know if awkward's the right word. I can't think. It's been a busy day. It does bring up, do I check a blood glucose in cardiac arrest patients? No, I don't anymore because I don't think it matters. But if I get them back, then yes, I am checking a blood glucose. And I think if I get them back and they're hypoglycemic, then yes, you definitely need to correct the hypoglycemia. I know that's kind of splitting hairs, it may sound like, but I think we should be treating what is immediately in front of us.
Yeah, no, it makes complete sense, Mike. I don't think it's awkward at all, because we have restarted that circulation system. You're getting the perfusion going. You're getting all these end organs perfused. You're getting things moving, and these glycogen stores that have probably been sitting, quite honestly, the pancreas has been not functioning. And by the way, for those that are wondering, we've done at least some research. We've talked to a couple different people, and the research on pancreatic function in shock states is really minimal. And by the way, CPR is the ultimate shock state. So it's just, we don't know if it truly works, but when it does work, when everything's back working and pumping, and
you can think
in a
of
raw state, and you can get an accurate number then. Sorry.
You can move through it logically, right, Josh? You move through it physiologically. Like when the body's in shock, what happens? We start shunning away from the things that we don't need in the moment, right? Heart, lungs, brain, period. Is the pancreas on that list? I don't think so, right? I think it's in line behind like liver and spleen too, right?
I mean, to be clear, we don't know that, Cody. I mean, unless Cody, you know that for a fact, we don't know that, right? And that's kind of the point. We don't know the actual functions. And I don't want to cut any of you guys off, but let's get back to the basics of it doesn't have to be advanced physiology, right? Mike already said the foundational treatment for cardiac arrest is good compressions and early defibrillation. We have to set the stage with that. So what we're talking about tonight is literally a microcosm of patients, and because we have the luxury to do so. So let's dive into basic physiology. Why do we need glucose? There's something called cell respiration that has to occur. 2 pathways that cell respiration can occur, okay? There is a anaerobic process that yields what? 2 ATP. What is ATP? It's the energy currency of the cell. When you have oxygen present, you then get 36 ATP. That's the most efficient way that, ATP gets produced. When we have hypoglycemia, your body has defense mechanisms to fix that. Things like gluconeogenesis, things like mobilizing stored glycogen, turning it into glucose. So I would argue that although the research is very limited, the logical known, we understand the general processes. So when we are and I feel like in my head, I'm kind of seeing it as oxygen or glucose. If we don't have that oxygen, we don't have oxygen in a poorly perfused state, we are now severely limiting our cell respiration, and we're only getting that 2 ATP. Oh, and there's also toxic byproducts that we know contribute to bad outcomes after return of spontaneous circulation. So I think it's important to review that basic physiology. Why do we need glucose? Why do we need oxygen? Glucose is that the first thing that goes into glycolysis, the Krebs cycle, and the electron transport chain. And in the electron transport chain, we have oxygen as a final electron acceptor to allow for those 36 ATP to develop. So I think it's just important to review those basics, because if you don't understand the physiology, then you're probably going to make some connections that you probably shouldn't be making. And I think it's important to have that early conversation.
So to tie it all together, Moose, basically you're saying, how we started the conversation of hypoglycemia is probably not a primary cause of cardiac arrest, right? Because to your point, the body has backup systems to keep that from happening.
Yeah.
Right. And for the guys that are like maybe a little bit lost is what we're talking about, this is Krebs cycle stuff. This is what module 1 in paramedic school is, Krebs cycle stuff. So
if you were lucky to have it, quite frankly, if you were lucky enough to have a paramedic program that reviewed it too.
True.
Or said you're never going to see this again unless you get into an argument on Instagram, right? Then you definitely need it.
I don't mean to cut you off, Cody, but to me, the thing that we just reviewed, we just summarized the case for 99% of cardiac arrests, right? Mm-hmm. I am sure that if I arrived on scene and someone was in full arrest and they said, oh, they killed themselves with an insulin overdose, or I don't know, I'm sure there's something, I'm just trying to be the devil's advocate here. I imagine there's some circumstance where I'd be like, after I do good CPR, after I do good cardiac care, good ACLS protocol, I can't believe I just said ACLS, but I'm going to say it, good ACLS protocol, then maybe if I have maybe 7 paramedics around and one of them isn't getting in the way and is being idle, maybe I might give. Am I checking a glucose? Probably not, because of I don't know. That was one of the things that FoamFrat had, where the reliability of a venous versus capillary blood sample. Mm-hmm. But it's certainly not high up in my list. And we all know how cardiac arrests actually function. There's an inverse correlation between the number of paramedics on scene. And Josh isn't going to like this. There's an inverse correlation between the number of paramedics on scene and how efficiently that arrest runs. Right? That's just a fact.
That's because if there's more paramedics on scene, it's probably fire-based EMS.
Oh my God.
I feel like I had the jab, and then Mike just sent with the crowd. Oh man, that was painful. But no, all I'm saying is we have priorities. First things first, right? Is one of my favorite sayings. Do the priorities that we know are going to save lives, and then in 99% of patients, just follow that. And if you get ROSC, then Mike said, absolutely, check the sugar. Absolutely.
I think, and I've been kind of like mum on my like official position on this whole thing, but I genuinely believe that the community at large is conflating two things. We're conflating causes of unconsciousness with causes of cardiac arrest, right? Of which, when you're working through a differential of you just see a dude down in the street, of course, depending on what street you find him on, you probably could reach straight for the Narcan, right? But there's a systematic thing, a system of things we work through. We work through dextrose, work through oxygen, work through Narcan, work through some other causes of unconsciousness. Versus cardiac arrest, it's like, you have no idea. You have no idea. And I just want to point out a fact that if CPR is generating 1/3 of normal cardiac output, and that is just to perfuse your nugget, are you getting enough perfusion out to this thing where you check the glucose from for that number to be reliable in the first place?
Absolutely not. You are totally correct with what you are saying. So this begs the question, is it time?
Mike, it's nice to know I'm not crazy.
No. Well, you may be crazy, but you sounded intelligent there.
Write it down.
Is it time to abandon the 5 H's and 5 T's and just focus on good CPR and defibrillation.
Mike, we did that in Maryland. We do not use H's and T's in Maryland. We have a rational approach to cardiac arrest, and we have a rational approach to PEA and asystole. I was the one
That's beautiful.
And I'll tell you why. There's a gentleman, I believe, by the name of Dr. Lazo Littman, and actually I'm going to Google that just to make sure I didn't butcher his name, that gave a presentation at the University of Maryland Emergency Cardiology Conference, and I want to say and he was basically saying that instead of having these blanket H's and T's, let's prioritize and execute what we know we can fix early. And
common sense.
Exactly. And it's like the big one is hyper K, right? And I'm going to bring up the actual algorithm. How we do it in Maryland is for PA and asystole, we differentiate is the QRS complex, right? Is a QRS complex wide or is it narrow? And then from there, start treating. Certainly, if you have a narrow complex PEA, then there's probably, hopefully, more of an obstructive etiology or a hypovolemic etiology. And if you have a wide complex a wide complex PEA, then you might have some sort of metabolic derangement. Exactly.
Yeah.
So if it's wide complex, prioritize early calcium. Early calcium really. If it's narrow, then prioritize epinephrine. It's really Lazo. Dr. Littman breaks it down into right ventricular function versus left ventricular function. I feel like that's kind of confusing. At least it was for me early on, though, when I was like actively listening to his lecture, and even when I'm teaching, I feel like I lose students when I teach it that way. But when I teach it in the way of the actual cause for shock, it seems to make sense. And like you said, it seems intuitive. Right? I don't know. I'd love to hear your guys' thoughts.
What is the treatment difference for right ventricular failure or arrest due to right ventricular failure? Like, you're not going to be given lytics for a PE in the field. So, like, what?
I'm going to bring up his thing right now.
No, that's definitely interesting.
I also haven't looked at this.
So while Moose looks for something I've always taught students, like, ACLS, like, there, and I'll hold on. I'll say, NREMT, when it comes to static and dynamic cardiology, they specifically look for H's and T's in asystole and PEA. And, it trips people up every time. Like, they're like, oh, in my VFib arrest, I didn't have to say that. But in my PEA asystole rhythm, I have to say it. And I always teach students, like, it's not cut and dry. Every cardiac arrest, regardless, you should be looking for possible etiologies early. Not just like, okay, well, I've done my EPIs, I've got my tube, I've got my IV or IO, and now I'm going to consider H's and T's. No, let's look at it from the start. What do we think this etiology is? I had one the other day that lady was on the phone in respiratory distress and dropped in front of her neighbor in the hallway. Pretty sure the etiology is respiratory. And that's what we need to start correcting with, that whole hydrogen ions, and there may be some obstruction going on, and believe it or not, talking about the narrow and wide PEA, she was in a narrow PEA forever. She was in a normal rate, and then she was in a tachycardic PEA. She had carotid flow, whole story, ended up transporting. She lived for like 24 hours in the ICU and then was declared brain dead. But that's you got to look at what is the cause to begin with, and let's, get the high quality CPR, early defibrillation, get our access, and then see what can we do to reverse some of these things. And like we said, Maryland went to, if you have wide complex PEA, hey, let's look, do they have a history of dialysis? Do they have a history of kidney dysfunction? A whole bunch of other things, and then treat from there. Calcium, bicarb, whatever is indicated.
Josh,
so for go ahead, Cody, my bad.
I was going to say that speaks to a lot of what Dr. Weingart talks about, right, on his podcast, of ACLS being like the floor of resuscitation strategies. That's what everybody uses. That's what the podiatrist uses. That's what not. And his point is that's not what people who are trained in resuscitation use, right?
True.
And I believe, and I think a lot of these debates and I'll say it, this is my hot take for the episode, I guess. These debates are mindless because on one end of the house, you've got the resuscitation mindset folks that are thinking through this logically and physiologically of, what's going on and what can I do about it. And then you've got this other side of the house that have PhDs in their protocols. They have mastered their protocol. They have mastered an algorithm, and now they think they know what they're doing.
There's
and that's
perfectly
not
fine
correct.
PhDs. To be clear, we have nothing against PhDs. I'm just saying a lot of them are friendly.
No. They have PhDs in protocol. That's what it is. They're so deep. I've memorized my protocol front and backwards, and that means I know what I'm doing. And that's where these mindless debates are coming from. I've done it this way for so long, I have to be right.
So can I ask this? Because I don't. So I think it's known already, but like Josh and Cody are the ones that handle our social media. What is the debate? If you guys can just summarize it, because I don't know.
You mean the original glucose
the original
debate?
Yeah.
Just that there is a side that says glucose checks in cardiac arrest should be done, and if you get a number, you should treat.
Okay, got it. Okay.
Here's also what I take it as people saying is it takes 2 seconds. Why not do it? What does it hurt? Well, like I always equate it to like you can what if everything to death. On cardiac arrest, I think we beat it home. You need to be focusing on the CPR and the defibrillation. I sound like a broken record. Yes, it only takes 2 seconds to check a blood glucose, but it also only takes 2 seconds to push Narcan, and it only takes 2 seconds to turn them over and inspect their asshole to see if there's fentanyl patches in there. I mean, we can do the whole it takes 2 seconds thing and go on and on and on. And not to sound like a dick, but I kind of had like a hissy fit or come to Jesus moment with myself. Because anytime, and I'm sure you guys are finding this out with the social media, anytime you post something, there's always like 3 or 4 people that have stories. Like, oh no, I checked a glucose twice last week on cardiac arrest and got ROSC. And I have now started to nicely, I'm not a dick, but I come back and I challenge it. Just like when I did a post a couple weeks ago on that STEMIs and simultaneous strokes are bullshit. They just don't happen. They have a 0.0009% occurrence. And of course, we've all seen stroke patients with like these wild EKG changes, and it's almost always going to be an aortic dissection. So I'm not exaggerating when I say tons of people either DMing me or commenting that, no, I've seen this happen twice last year. Last week we had this and the patient went to the cath lab. Well, that doesn't mean that the physicians were right, that it was a STEMI. I mean, we all know that like they'll see ST elevation and blindly send them to the cath lab when there's an arrow sticking out of their chest. And it's like, I don't think that's the problem. So I have started coming back, and with this STEMI and stroke thing, like, if you can give me a case report, and you can get this information from like cath labs, they'll give you anonymous follow-up. Like if you could give me a case report and what was found, I will put it on the podcast and for everybody to see. And nobody got back to me because they hear like, they hear like, oh, the nurse told me that they had an MI and went to the cath lab. Well, no, that may not be accurate. Or the ER doc thought it was this. Well, anybody who does critical care transport knows that that's like flipping a coin with whether it's accurate or not.
Yeah.
I'll shut up.
I always tell people, you know what, if it, like kind of go off what you're saying now, if people have something to bring, I invite them on the show, but then I just say, for lack of a better term, be ready for the smoke, right? Like we're not going to just let you come on and talk. Bring the physician that told you that, right? Bring the physician. Bring the objective evidence that what you're saying is right. And you're right. I honestly, I bitch to the guys all the time. No one will take me up on my offer, and it's kind of frustrating.
Because that's the point. That's the whole point, Moose, is you use two words that when you put together, it scares paramedics: objective evidence. And and I'm picking on paramedics, I know, but I'm so over the mindless debates that revolve around a personal anecdote. This is 2024, and we're trying to push paramedicine toward an evidence-based, whatever that definition is, right? But toward an evidence-based practice. And I'm sorry, but I have a social media page, and I blather on about nonsense all the time. But nobody should ever stake their career and their reputation on one of my anecdotes, ever. And the most reputable folks are out there saying, listen, this is the world according to me. Go read the research yourself. This is something, even in the early days of the MCRIT podcast and the Flight Bridge Ed stuff, when EMS podcasts were really getting going, they always say, listen, don't stop at the abstract, read the paper for yourself. Read the evidence for yourself. And I actually just finished a peer review on a CE course for another individual, for another company. And I was like, hey man, 90% of your references are blogs about papers. So go back and read the paper and use that as your supporting evidence for this point that you're making incorrectly, but that's the point that you're making, right? Yeah. But we so often we stop at the blogs and go, there it is. And your whole frame of reference is somebody's opinion. Yes.
I would take it one step further and say, even if you're reading the paper, are you able to gauge the methodology? Are you able to gauge the powering? Are you able to gauge I would argue what I always do is I try to find my mentors that are very good at academic research, and I ask them, hey, what am I missing? I'm in a graduate program now, which is now in epidemiology and preventative medicine, right? And I'm in a biostats class right now. And every lecture, I'm like, holy shit, I didn't know that, right? And I'm like in week 1 or week 2 of the class. Who knows where I'm going to be in like week 7, right? So I would take it a step further. While you're reading the papers, understand the limitations of your own knowledge and be respectful of it, and understand the value of consensus through like talking to experts and various experts. Because I'd argue that even one biostatistician or one expert physician may not have the right take. You're going to have to talk to a few folks.
And it's crazy, Moose. And I hate when I start a sentence that way, but how many paramedics know the difference between a study that shows association versus causation? Or, and then, my whole world is based on this study. I was like, well, that was association, not causation. And even and to highlight a point, and Ricky Dietzel is a good dude, and he was super friendly, and he helped out my organization too. But it's not his fault that he put out a study and he said, hey, this might be a problem, and the industry went nuts with it and socialized the treatments that we're finding out now that we're having to go back, just like with this stuff, go back and go, do we need to push a gram of calcium every single time? And how much how much is the chelation actually reducing calcium and all this other stuff? And it's not his fault.
Yeah, we're not trying to be condescending here, right? Like, if anything, I'm trying to stress that none of us don't know what we don't know, right? We don't know what we don't know. And the fact of the matter is, you're right, man. Retrospective investigations versus prospective investigations, right? These terminologies that they matter. And I certainly respect where you guys are coming from. Yeah. Mike, I think I cut you off.
You don't sound condescending at all. You sound like a responsible consumer of research. You gotta.
Don't tell him that.
Yeah, I know. Let's see his head getting bigger. You can't. Yes, you can't just read the abstract, but you go in, you read the data, and I also like to look at what are they referencing in their paper. Do some background. Where did this study come from? You got to be careful with what people are retweeting and just blindly posting. I'm reading a book right now, completely unrelated to any of this. It's about the opiate epidemic. It's really interesting. It's about like the people in Mexico growing up poor, doing the drug running, all the way to like how big pharma and big medicine got involved in getting people hooked on opiates. And granted, they didn't have Twitter and social media back in the 80s, but I don't know what the version back then of like the retweet button, I guess letters to the editor and citing and other papers. Anyway, one of the things that big pharma put on blast to physicians was this thing in the journal called Pain, written by a pain specialist, citing that if you give opiates to patients who have chronic pain, they are not going to get addicted. And they put that on blast, and people were like, whatever the 1980s version of retweet was. And this doctor who wrote this article kind of got vilified once everybody was getting hooked. And he was like, no, 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 no. He said, this was a letter to the editor that I wrote. And he said, and yes, I said that you can give opiates to patients with chronic pain and they don't get addicted if they have an easily identifiable cause and they are in the hospital getting treated for that underlying cause. Then you can safely use opiates to keep them comfortable. He's like, I never was saying that opiates aren't going to get every patient hooked. You know, if you send somebody home with OxyContin, like, yeah, they're going to get hooked on it. So you got to be really careful because you don't know what someone's twisting. I just did a reel last week where I was shitting on ASAP for needing to get on board with the, like, let's get rid of C-collars. And I looked at what they cited in their position statement. It was crap. They were citing position papers that they wrote. They were citing position papers that the American College of Surgeons wrote. There wasn't much research in there. There wasn't much studies.
And Mike, that's a good point too. I part of my peer review responsibilities is looking through a reference list and finding where they've plugged it into their presentation and things like that. And I was astonished at some of these talks that their references were stat pearls, up to date.
Yep.
And that's great. They exist for a reason. They exist for 3:00 in the morning where you're like, I fucking forgot how to deal with XYZ, for a physician to look at this but it's not designed as a what do you call that? As a robust enough source. It's still scholarly, don't get me wrong, but it's not robust enough to
change practice,
or educate from. That's what I was trying to think of. It's not there to educate from. It's there as a reference. That would be no different than, picking up your flip book, your UMBC critical care paramedic flip book, and starting to teach hemodynamics from it.
Mm-hmm.
Yeah. There's no real meat to it.
I feel like I should probably stop sharing my screen, or we should talk about this real quick, only because it's going to be awkward when people just tune in.
Okay.
All right, so Mike, this is what I was talking about, right? So, and to be fair, you're absolutely right. Are we going to be giving lytics in the pre-hospital setting? No, but I don't think this guy was talking. This was an emergency medicine conference. It wasn't a pre-hospital medicine conference. So he's talking about treatment in the hospital, right?
So it was smart people.
Well,
I'm just joking.
I don't know about that. No. Please let me come back next year, guys. Their conference is actually April 5th, I think. But yeah, it doesn't matter. So like I said, breaks it down, QRS narrow, QRS wide. QRS narrow considered to be like some sort of right ventricular obstruction, which makes sense, right? This is how we teach shock. And the treatments are, it's a little dated, right? Obviously, if they need blood, you'd give them blood instead of fluids. But you relieve whatever that mechanical obstruction is, which is decompression, lytics. And I wouldn't tell people not to do CPR here, but the idea is that we should be figuring out why blood is not flowing because the cardiac function is intact, right? On the other end is that he talks about the left ventricular failure, and that's what I was talking about with the metabolic causes. The only kind of like rule the only time this rule gets broken is he talks about it under the most common metabolic causes, quote unquote, is it's not metabolic, but the STEMI with agonal rhythm and other agonal rhythms, right? Because we know that idioventricular wide complex normal rate, but that wide complex rhythm is not associated with a metabolic issue. But this is what I'm talking about. And last thing I'll say is most common mechanical causes that he says for that narrow QRS complex with RV obstructions, cardiac tamponade, tension pneumothorax, and massive PE. The most common metabolic causes, he says, are severe hyper K with or without metabolic acidosis and that sodium channel toxicity. This is what I submitted a couple years ago to our state EMS medical director, and he went forward with the protocol. And that's why we have the rational approach to PA in Maryland now, because of I see that I see H's and T's as a flat scale with no prioritization, right? Whereas now we have a prioritization of fixing the things we can fix first. And I'm going to stop sharing now.
Before you do, I want to
sorry.
the bullet. Well, the bullet about when you're a narrow complex PEA or a pseudo PEA, and it's telling folks to be careful with meds and CPR and stuff like that. I think folks really, if there's anything that you take away from this whole conversation, it should be that. It's to pay attention to what you're doing and know that, hey, with that pseudo PEA, mechanical obstruction or whatever it is, by doing the norm, by doing the regular CPR, the regular ACLS stuff, if you get ROSC by doing it that way, you may not keep it. And you may be ruining their chances at a meaningful outcome. Maybe, not always. I don't want to make a blanket statement. But if you mismanage it and you accidentally, and you get lucky and get a ROSC, don't spike the football on that one.
Great point, because I don't have it in front of me, but reading up for this, one source did say that dextrose administered to the hypoglycemic cardiac arrest patient does have slightly increased rates of ROSC, but almost globally poor neurologic outcomes. So,
I have that.
You got him back. You're going to get your little Phoenix Award, but congratulations, you've become a vegetable farmer.
Yeah.
I think that one specifically also highlights D50 as like one of the leading. Like if you're looking at dextrose, D50 is even worse in the realm of what we're given. And I know there's still agencies out there that are using it. Not everyone's converted to D10. So if you got someone that is still thinking, hey, I need to slam this amp of D50, well, it's kind of like all that hard work and it just falls apart.
Do you know now that we're getting so old, or at least me, that I now am seeing paramedic students who did not know that we used to give D50? They're like, what's that? Like, oh, you used to push dextrose? Like, oh my God. Don't even get me started about Bertillio.
We're replacing the guys who are like, gold box, pink box, blue box, big shock, little shock, everybody shock, all that. We replaced them, and now we're like, no, we've got these bags. What's D50? What?
How about
it's the blue box.
Ever give thiamine with D50?
How old are you, Josh?
I'm not.
I never have, but I was taught it.
But
785 years old.
I came from a system in Texas that was still doing it. And by the way,
you're going to give them the wet brain.
But interestingly enough, to touch another piece of that was part forever. That was part of the unconscious cocktail, the coma cocktail, right? Dextrose, oxygen, Narcan, thiamine.
Yep.
And if they didn't wake up after that, they didn't tell me what to do next. So
yeah,
you shake.
I think we can stop sharing at this point.
Yep.
Speaking of doing stuff just to do it and go down the protocol that you probably know is for naught. I had an old guy who was 89 2 days ago. He's fine, and then an hour later his wife found him out in the camper out back where he likes to tinker with his toys and stuff. She found him unresponsive on the couch, and he had this new left facial droop, and he had these like jerking motions of his arms, which came to find out signify basilar artery occlusion, but that's not till I read up on it later. But I was like, I'm like, he needs to get tubed, no doubt about it. But I'm like, oh my God, I cannot believe I am pushing Narcan before I'm dropping this tube, just so I don't need to hear about it.
I'd have took the ass chewing, Mike.
I was like, fuck it.
I'd have took the ass chewing.
You know, I will say, though, and not to be one of those social media commenters that I was just bitching about, I did have, this is just one time, I'm not saying change practice, but I had an old man that was found unresponsive in his car, and this was, back in the day, coma cocktail. Sugar was normal. I gave him Narcan. I'm getting ready to, do other stuff, and then he sat up and admitted to using heroin. I was like, what? Like, you're 82.
Hey. Don't judge, Mike. Come on, man.
I know. I know. But yeah, I pushed Narcan and I felt dumb, which I'll take the chewy. I should feel dumb, but
I used a long spine board yesterday, and I know what you mean.
All right.
I know what you mean.
Just to move the patient?
That was the plan. And then I'm still new, so I'm still in the FTO phase where your opinion it doesn't really matter, but we want to know what decisions you're going to make, but we don't care what you're going to say. And I was like, we're going to take them off. Nah, we'll just leave it on there to help splint the thing.
Sure. Yes, sir.
I would also be careful on what you say, because where you work now, people definitely listen to this.
Check.
I'm just saying. You do you, boo.
Oh, I
wasn't judging them. I was judging me.
I had a full prima donna moment on Friday working my flight job. We landed at what sounded like a spicy car accident, and I think the patients could have gone to a community hospital because they can deal with an ankle fracture, but they were fully immobilized. This was a backwoods EMS crew, fully immobilized, fully clothed. And I'm like, why the fuck are they on this backboard? And I was like, shut up. They're going to complain.
Easy, Mike. There's certifications for backwood medics now. Wilderness paramedic certified.
Dude,
You're trying to
social media people were going to piss off tonight.
You're trying to lure me into saying things that I shouldn't say.
I did a lot of fishing as a kid. I know how to catch them. Get the bait out there for you. Ooh.
Oh boy!
I'm getting fired after this.
Yeah, I wonder if a paramedic practitioner would treat the H's and T's any differently. Oh, shut up! Sorry, I couldn't resist.
No, I saw it. I know. We differ here a little bit, but I wanted to come back with the paramedic practitioner would understand the science. But you would hope, at least.
He's fighting so hard.
I am.
Stick your hands out in front of you. Hold him out in front of you, Mike. Don't let him arm drift. Hold him.
I know. Yeah.
He's about to have a stroke.
Oh, you might see some flapping tremors. So do you guys give Narcan? I know you said you talked about this before. Do you guys give Narcan to your opiate overdoses? No. Fuck no.
This is an episode that we, when Ken and I first started this fucking thing in 20 whatever, this was one of our earliest episodes that we talked about with our then medical director. Yeah, no, why? Why? I don't know. My blood pressure's going up just thinking about it.
Yeah.
Just to clarify, you're saying opiate overdose arrests.
Arrest. Yes.
Yeah.
Yes.
Okay.
Yeah. I was like, wait a second. Did we just go into a really
no, I've read the blogs before where people say, "Oh, you shouldn't give Narcan to the opiate overdose. You should just intubate them and let the drug wear off."
Oh.
Do you know what would happen if I walked into a Philadelphia ER with an opiate overdose and said, "Oh, it's good patient care, so I just intubated them. We're gonna take up an ICU bed for a few hours."
You'd be. Oh my god! Sorry.
They would say, "Go back in your car and go fuck."
No
yourself.
one says
That's
that, right?
insane.
No one actually says the whole what the intubation thing, right? I mean,
there were a chain of events that led up to me starting the podcast back in 2020, and this blog. I'm not going to say who wrote it. I'll tell you guys when we're not recording. I commented on it, and they came back at me and said, "We had excellent constructive conversations, except for you, Michael Carunchio." And I came back with, "No, just because you don't agree with me doesn't mean it was not a constructive comment."
Why would you want to intubate and provide positive pressure ventilation to somebody, increase infection risk, and increase a bunch of other negative things when you could just give them a med and they take on their normal physiology?
Well, Moose, for two reasons. One, they become violent after you give them Narcan. And two, it could cause pulmonary edema.
Oh God, not that
Hyperemesis.
again.
Hyperemesis. Don't
Oh
forget that
my
one.
fuck, dude! Every time I fucking hear that, I feel like it pops up every few years. Well,
I
first
have
of all,
given
if they're getting violent, you're probably giving it either too quickly. You're not fucking resuscitating him first at all. You're not bagging for him at all. You're not doing anything of that right. And then what was the second thing?
pulmonary edema.
Which is like in the most minute of cases.
And it's in the patients who get like 16 milligrams of Narcan. But yeah, so I've given Narcan to shit, I don't know, 22 years, over 1,000 times easily. And I've only twice had patients get violent. One was a guy who was hammered drunk on top of being opiates. And we all know that alcoholics can be assholes, or I shouldn't even say that, just the drunk person. And the second one, the fire crew that responded was so antagonistic to this guy that's what made him violent. And I'm like, I don't blame him. I would have tried to throw a punch too if I were him, and they were talking to me that way. So now they get annoying.
So-
Do I like the patients that I Narcan? They may be whiny and rude and bitching and nasty, but as far as violent, no.
You know, and to get it back to the cardiac arrest bit of using Narcan or using any medication whatsoever, but particularly this one's a little spicy for me, in the sense that, okay, so we're pushing it probably through an IO, right, guys? Maybe a tibial IO, distal, and then we have to generate enough arterial pressure to move said medication to the receptors in a volume at which they can actually compete for and occupy the receptors. Does that sound right? Is that that's our logic?
Makes sense.
That we're approaching that with?
I mean, that's the science behind the logic. Yeah. If we really want to look at it, and, you know, other than just say, like I said to someone earlier, they're not suffering from hyponarconemia. Like when we're looking at it, like, we literally have to do so much work for this 2 milligrams of Narcan to work.
Yeah.
And it's not. In the end, it's all that work, all that effort to even think it's going to happen. It doesn't work. It's not how this happens. It's a hypoxic arrest. How do we fix that? Early CPR with ventilations, early defibrillation if we can find it. And like I said earlier, these people are starting out hypoxic. Your timeline to get to them, it's tiny. It is shrinking by the literal second. And that goes for any arrest. Honestly, when it comes down to it, your chance of ROSC is shrinking by the second.
So yeah, I say that to kind of highlight the point that of anchoring on medications, and to tie what you were saying, Josh, and what Mike and what all you guys have been saying from the get go of, it's all about CPR and defibrillation. It's all about perfusing the body, perfusing the heart and the lungs and the brain. And I would challenge individuals who believe that pushing XYZ X medication, whatever it is. I think epinephrine is important. We should be doing it every XY, at so many intervals until we get ROS back, if you get ROS back. But you have the same problem. They're hypoperfused, and you, the human, are now the pump that is functioning as the heart, and you are only generating 1/3 of normal cardiac output. And are you actually moving that medication to the receptors at a rate and a volume to which it's having the effect that you think it's having? I just challenge you guys to ask yourselves those questions.
Well, not even you. You're spot on, 100% correct. This isn't like disagreeing. This is to supplement what you said. You're acidotic AF when you're in cardiac arrest.
Yeah.
And your meds don't work optimally if you are acidotic. That's why the septic shock patient, you need to relatively rapidly add a second, third pressor, titrate up, because the pressors don't work as effectively in an acidotic environment.
Could make a case for vasopressin. It behaves better in an acidotic environment, but there's still a point. Like your pH 6.8, 6.9, that ain't shit working for you.
Yeah.
Maybe we should give bicarb to buffer the blood and so the pressures on everybody.
It's not dead yet. It's not dead yet. There was a recent study that came out. I did a post on it a while back because I was like, can we just stop giving bicarb? And I may have it reversed. but in PEA and asystolic arrests, it was associated with like a percentage that they said was statistically significant. I'm not a researcher. It was like 1.4%, not just better ROSC, but like actually like meaningful resuscitation.
Survival to discharge.
Yeah. Now it didn't have anything about like neuro outcomes or anything, but now it made no difference in the VFib VTAC group, but in the PEA and asystole, they did have some success with it. So I don't know. I don't give bicarb in cardiac arrest, but
and it's the whole bicarb debate. Mike saying, can we just get rid of it? Like, can we just get it out of our algorithm? And I know it shouldn't be gotten rid of completely. It has its indications, but like, hey, can we be more specific on the indications? And back to what Moose said earlier about Maryland going towards that route. Like, even my agency, we don't carry the Bristow-Jet version anymore. We carry a vial form because we're looking to use it for other things other than cardiac arrest. We have it there for, they're getting rarer and rarer, the TCA overdose.
Well, if you make it harder for paramedics by making them draw it up, they're not going to use it. So
I'm just saying, Chief, you know who you are if you're listening. And if that was your goal, good job, because that stuff sucks to draw up out of a vial. But
they beat us at our own game.
Yeah, they got vials, and it makes it harder. Like, you actually have to think, like, do I need this bed? Is this indicated right now? And
it also makes you more acidotic.
Yes.
So unless it is an issue of the kidney not producing bicarb, then it's not going to help, because to go into this whole Krebs cycle thing that Moose talked about. What is it when bicarb interacts? When it gets metabolized, it breaks down into water and CO2. Mm-hmm. So you get CO2 being a Lewis acid, as somebody once pointed out to me. CO2 is not an acid. Well, it kind of is. It's a Lewis acid, but it indicates acidosis. So you're actually like getting a transient increase, or an increase in the pH. So people are like, oh, I gave it to this crashing septic patient and they got better for a minute. Well, yeah, but then they're going to get more acidotic once it metabolizes.
And there's two points to that, Mike. And one is that's a real acidosis. And if you don't have room on your ventilator, so in the critical care world, if you don't have the room on your ventilator to increase your minute ventilation safely and not kill their lungs, don't push that bicarb. Don't do it. And the other reason, okay, they got better. It made my pressors work. No, it didn't. It's super hypertonic. And you probably got a huge volume shift into the intravascular space when you push that. And that may even be in that PEA arrest state. If that was a pseudo PEA and they got a huge volume load or a huge volume return back to the heart, of course it restored perfusion, or a palpable pulse.
Yeah.
And of course your hemodynamics got better, and then they went right back to where they were, because to your point, Mike, all we did was shift acid. That's all we did, is we took it from this side of the carbonic acid equation over to this side of it. And you have to get it out, or to what your point, you're just making things worse, man. You're literally making things worse.
So the paper you alluded to, Mike, was by Naderberger et al. Sodium bicarbonate administration is associated with improved survival in the asystolic and PEA out-of-hospital cardiac arrest. It was published in Resuscitation in 2023. Why can't I? I don't know why I can't see the specific issue here, but no, it's certainly a retrospective analysis of. So they analyzed 23,567 records. And yeah, what's interesting though is if you dive into the actual methods, right? And where did I find this? The EMS ROSC and survival to hospital discharge rates were 18.4% and 7.6% overall. ROSC and survival rates were highest among those with a presenting rhythm of VFib or VTAC, followed by PEA, and then asystole. Among those who received bicarb, 15.2% experienced ROSC during the EMS encounter, and 4.9% survived the hospital discharge. In all presenting groups, patients who received bicarb were more often patients that had unwitnessed arrest. Non-EMS witness arrests long resuscitations, and many adrenaline doses. In asystole and PEA, patients receiving bicarb were less frequently Black, more frequently Hispanic, and had more use of, and I think this is huge, CPR feedback devices in addition to other differences seen in these distinct rhythm groups. So I'm not saying that's a blatant confounder, but it's certainly, and I imagine, I literally didn't know about this paper until you mentioned it, so I'm going to have to read through it. But I imagine in their limitations section, they're going to say something along those lines that there may be confounders. I'm not saying don't use bicarb, right? What I'm saying is make sure you're using it with intent. Is there a tricyclic overdose? Is there some sort of acidosis?
Of a paper that may be excellent science, may be spot on, but it still does not mean you can just blanket change things based on it. Just like the SGA causing asphyxial pathology. Great freaking paper. Great research methods, but I don't think you can generalize it to everybody yet.
Yeah, no, absolutely.
We sound like a bunch of fucking nerds, man.
A bunch of blowhard nerds. That's what
Yeah,
we are.
I know.
A bunch of blowharded nerds.
I know, solid paper,
we,
man.
we have
I
an EMS podcast. We're nerds.
Yeah.
Yeah.
Plain and simple.
Yeah.
Thanks, Josh. Thanks. Brought it right home. I could put all the skulls I want on my t-shirts. I'm still a nerd at the end of the day.
It's like that reel of that guy singing, "Virginity is cool."
Oh, man. Ugh.
Wow.
How long have we been recording for?
Just over an hour.
Just an hour.
Time flies when you're having fun.
Yeah.
Yeah.
Or when you're getting your blood pressure up from Cody's dumb statements.
Anything else we want to talk about? I mean, I think we hit some controversy in cardiac arrest care.
Yeah, no, I'm happy with it.
Yeah. And just controversy about reading studies and believing everything you see.
You don't need to be a freaking paramedic practitioner or a professor to read and appreciate studies.
But you do need to have a proper education on how to read them, or ask somebody for help.
Yes.
Oh, okay. Well, I think that wraps up what we set out to talk about. Guys, anything else?
Oh, apparently virginity is cool. Oh God, I'm laughing.
There was a lot of hot takes that we said tonight. This is probably one of our spicier episodes.
Yeah.
People like spicy though.
I don't think I've ever said bukkake before on a podcast.
Holy shit!
I all right. Maybe if this is already spicy enough, but my parents are devout Catholics, and my dad is the complete opposite of me. He's just soft spoken. He's just a humble guy, and he retired last year from like a nearly 50-year career as a neurologist. So we had this sweet old couple that lived next to us growing up. And in the middle of the night, one night when I was in college, the old man knocked on our door and said he thought the old lady was having a stroke. And she was having a big stroke. And later on, after the paramedics came and took her to the hospital, I said to my dad that maybe she got so hot and bothered during the bukkake party that like she threw a clot off of her valve. And my dad, he got mad, and I said, I looked at him. I was like, "How do you know what bukkake is?" And then he got even more mad. He goes, "I just assumed it was something because you said it."
You know,
Like, Dad, you better put in your will we delete your browser history.
Yeah.
I can't think of a better line to finish on.
There you go.
Oh, that was great.
Well, Mike, thanks for coming on again, and
Sure.
in this great spicy podcast about controversy and cardiac arrest. That's what we're going to say.
And bukkake.
Controversy and cardiac arrest. And bukkake. Okay.
Yeah, make that the title: bicarb and bukkake. Sleep down.
So, Mike, once again, thanks for coming on. Awesome episode, controversy and cardiac arrest. Obviously, if you're not following us, if you're not following Okayest, you're doing something wrong. You need to follow him. He puts up some great stuff.
Some people unfollow me.
It happens. But he has a great podcast, great social media page, and great information put out constantly. Thank you for coming on. Thank you for listening.
For having me.
And wherever you are, good evening, good morning, good night, whatever it is, be safe.